We've discussed CCR5 and CXCR4 already, I think, this morning, so I won't go too much into this, but CCR5 is clearly the most commonly used co-receptor. Pretty much all transmissions of HIV are CCR5 tropic viruses. A mutation was described, or a 32 base pair deletion was described back in the 90s by a number of groups, and this was shown to confer resistance in patients who had 2 deleted copies in their genomes. And approximately 1% of all Europeans have this double deletion or delta 32 deletion. So that's been a very important observation that now has, as you will see, been translated into to long-term remissions. So this is a slide showing you what happened with the Berlin patient. I'm sure many of you are familiar with this. This was an individual who was suffering from acute myelogenous leukemia and who was teed up for a bone marrow transplantation procedure. Here you've got the viral load on the y-axis and time on the x-axis, and this individual was viremic, was given ART, and underwent a first stem cell transplantation procedure, achieved very quick donor chimerism, as you can see here. In order to deplete cells, his chemotherapy involved using not only ATG, that's antithymocyte globulin, followed by cyclosporin and MMF. So this first transplant, unfortunately, was not successful, and the patient required a second bone marrow transplant from the same donor, and at that point received total body radiation both times, in fact, so received pretty much the same regimen second time round. So this was a double, he underwent 2 transplants within the space of about a year and a half, so that's quite a remarkable thing. And following the second transplant, donor chimerism was achieved and maintained, and you can see here the viral load remained undetectable. In fact, this patient interrupted ART pretty much at the day of transplant, which is amazing, and that was due to concerns, of course, of ART back in those days, interacting with chemotherapy. So Tim Brown, the Berlin patient, has been free in remission for around a decade, but although it was a huge success story, a number of questions still remained in terms of what was important for that cure to be achieved. Was it the chemotherapeutic regimen? Was it the fact that he needed 2 rounds of treatment? Total body irradiation, was that important? And what was the role of graft versus host disease? Tim Brown had mild GVHD documented, or was it something that was specific to the patient? I think that certainly was a possibility. So we had the opportunity to try and answer some of those questions through an individual who came to my attention back in 2015, and this patient was HIV positive since 2003, and 10 years later was diagnosed with stage 4B Hodgkin lymphoma. He had not received ART for those 10 years, probably contributing to the development of lymphoma. And at that stage, this patient started a tripler and achieved suppression. And following that diagnosis of lymphoma, was started on tenofovir FTC raltegravir because he was going to be on chemotherapy. Unfortunately, the chemo was unsuccessful despite great efforts from the hematology team. The next step there is autologous transplantation, and unfortunately they were unable to mobilize enough stem cells in this patient, so he was basically told that there was nothing left to do. What happened then, he was referred to a second center for an allo transplant, and at that stage they thought of doing a transplant using donor cells from a delta 32 donor, and luckily they were able to find in the European registry patients with a 9 out of 10 match. So the highest match happened to be a homozygote for delta 32. So that was quite fortunate. I received a phone call around that time saying, there's this patient, and you're a virologist, would you like to help us or to study what's going on? Unfortunately, fortunately, the patient was actually one of our HIV patients who I'd never met, but that facilitated the whole process because he was then under our care for HIV within our center. So he was teed up for allogeneic stem cell transplant with LACE conditioning. These are the drugs they used. This was back in May 2016. He was hospitalized for about a month and developed some of the usual things that are associated with transplant procedures, sepsis being quite notable. He also had colitis after discharge and underwent OGD as well as colonoscopy, and there was mild to moderate inflammation, and the diagnosis of GVHD was made, but actually no treatment was given, and this subsided. He also importantly had CMV and EB reactivation around the same time as that colitis, but the stains the gut stains were negative for CMV. Those two reactivations were treated with ganciclovir rituximab, and this diagram shows you the time course in this individual. So one thing I haven't mentioned is that before the transplant, this is the viral load, he had a sort of semi-treatment interruption because of various factors, and experienced a viral rebound to over 1,000 copies. But really importantly, during that time, he developed a K65R mutation to tenofovir, M184V, as well as E157Q. So that was pretty remarkable. We managed to get him suppressed again before the transplant using rilpivirine, dolutegravir 3TC once daily. And so having achieved virologic suppression, we went ahead with the transplantation procedure, and all went fairly well. 100% chimerism was achieved very quickly, within 30 days. And as I say, we think he had mild gut GVHD, but we'll never really know. His immunosuppression was stopped after 6 months, and here you can see the CD4 count in red. Obviously was low during the transplant procedure. Importantly, in this case, he received anti-CD52 for lymphodepletion in contrast to ATG, and what that does is leads to quite a slow recovery of CD4 cells. So that's a well-known side effect of using anti-CD52. So having achieved undetectability, even by ultrasensitive assays in plasma, we decided to interrupt treatment in September 27. At that time, around the same time, he had a PET CT showing complete remission, metabolic remission on imaging from the lymphoma, and the viral load remained below limits of detection out to this is February 19, but now of course we are in May, so we're now at 20 or 21 months of complete remission. A number of assays were done to further verify this. So this in green is the HIV proviral load in CD4 cells. It was around 6,000 to 7,000 per million CD4 cells before, and has now gone below the limits of detection. And in collaboration with the ISOSTEM consortium, we've done a number of assays to look at very, very low levels of DNA in his CD4 cells, and pretty much all of them are negative except for 1 out of 8 digital droplet PCRs. So we have also maintained 100% donor chimerism, importantly, and as I said, the proviral DNA has been pretty much below limits of detection. We've also done viral outgrowth assays on a total of around 22 million resting CD4 T cells, and we haven't had a single reactivation documented across 3 or 4 viral outgrowth assays. That was done by Andrew Lever's lab in Cambridge, using a slightly modified protocol from Silicano. So I'm just going to quickly show you some other figures from the paper. So this is a gel just showing you that the CCR5 deletion was achieved post-transplant. Thomas has very nicely told us about Tisney plots, and this is a Tisney plot of his lymphocytes, and you can see here the CD8s are in blue, CD4s are in orange. And the red CD4, the red is CCR5 positive cells, and purple is CD8 positive, CD8 and CCR5 positive cells. You can see here before the transplant there's CCR5. You can see here in red overlying the CD4 cells as well as the CD8s, and after transplant you can't see any red or purple, so suggesting that you've lost expression of CCR5 after the transplant. We then have looked at the susceptibility of his circulating CD4 T cells. In vitro, we've taken PBMC and then experimentally infected them with 3 different viruses. You can see this is BAL, this is an R5 tropic virus, ZM247, which is a clade seed founder virus, and then our friend NL43, the X4 virus. So you can see here that the R5 virus is able to is not able to infect the patient, and nor is ZM247. But if you use an X4 virus, these cells are fully infectable. And the control on the right here shows you that if you take a healthy donor and infect their CD4 cells, you can pretty much infect them with each of the strains. So again, confirming that this patient has lost CCR5 expression and is now resistant to R5 infection. The plots here are just quantifying the data. So. Then we needed to, you've shown that you've got resistant cells now in the patient. We then have to go back and make sure that he doesn't have any X4 virus, because of course there's been one case where Delta 32 transplant was done, but actually there was a rebound of pre-existing X4 virus in that patient. So we needed to check that this patient didn't have any X4 virus. So we did single genome amplification of V2 to V4. We constructed this phylogenetic tree. We then cloned those sequences into a backbone to produce pseudotyped virions, and we then infected cell lines that either express only CCR5 or only CXCR4. These red lines are showing you a control virus that is dual tropic, that can infect both cells, and you can see, of course, this is a relative light unit, so you can see there's an infection using that red virus, dual tropic virus in both cell types. But in the patient-derived sequences, and remember, these are sequences derived from PBMC before the transplant. So this is looking at what his reservoir was like before transplant. You can see these viruses were able to infect these CCR5 expressing cells, but his viruses are not able to infect cells that only express CXCR4. So this patient, we concluded this patient was infected with pretty much exclusively with R5 virus, although of course you can't prove that. What about evidence for loss of for cure or remission? One thing is to look for loss of immune responses. So looking at antibody responses, you can see this is Western blot showing various bands, and each of these is, and this was done by Javier Martinez-Picardo's lab. You can see over time there's loss of these bands over time. So that's reassuring, suggesting lack of challenge to the immune system. The standard ELISA remains positive, but the detuned ELISA and avidity assays all show a drop over time. And on the right here, I've shown you data from Tim Brown, and there was a very nice correlation between the 2 patients you can see over time. So those data were published by Steve Deeks and Uckel back in 2013. So we've demonstrated a pretty similar pattern to the Berlin patient. And then finally, we looked at HIV-specific T-cell responses, both CD8 and CD4. Up here you can see unstimulated cells before transplant. There's nothing in this box, but if you stimulate with HIV-1 GAG, you can see there are responses before transplant, and this is a control CMV. You can find T cells that respond to challenge with PP65 antigen from CMV. So this is before he underwent the transplantation, and then afterwards you can see, for example, these are various time points, but let's just take day 96. You can see that there is virtually no response to HIV GAG anymore. Comparing up to up here, but the patient still has responses to CMV, and of course he had a reactivation, so we would expect that to be positive. So this is again telling us that the immune system doesn't seem to be seeing HIV-1 proteins. We have the same data for CD8 and CD4 specific responses. And so, just in summary, just to kind of start wrapping up, these are some of the differences and similarities between the two. The London patient was homozygous for wild-type CCR5, whereas Tim Brown already had one copy of the Delta 32 genotype. So both had R5 viruses at baseline. The two diseases were different. They had 1 versus 2 transplantation procedures. Tim Brown had radiation and the London patient didn't. Tim Brown also had more intense conditioning and T-cell depletion with ATG, whereas we used anti-CD52. So a number of important differences there. But overall, the procedure was certainly much milder for the patient and better tolerated. Both had probably GVHD and both achieved 100% donor chimerism pretty quickly. So in summary, we've got 21 months of remission with no viral rebound. We don't see any evidence of immune responses at the moment, and I guess these two cases really sort of point to the use of or manipulation or translation of CCR5 deletion strategies as a potential curative intervention. In terms of what we're doing next with this individual, he's going to have an MRI and lumbar puncture to look for virus in the CSF compartment. Although I don't expect this to yield any positive results. We're still thinking about further sampling, and potentially we'll use a mouse QVOA assay to take some of his cells and try and infect humanized mice. And I'd like to take questions. Thank you very much for your attention.